Welcome to this comprehensive module on the fundamentals of nutritional psychiatry. Today, we are focusing on the powerhouse of psychiatric nutrition, the B vitamin family, vitamin D, and their critical role in regulating homocysteine. This isn't just about general health, it's about the biochemical foundation of mental wellness. We will explore how these nutrients directly impact your clinical outcomes. In PMHNP practice, we are facing a hidden epidemic. Nutritional deficiencies are often the missing piece in treatment-resistant cases. Data from the provided research shows that 70% of adults and 67% of children in the USA have inadequate vitamin D levels. When these cofactors are missing, the brain's ability to synthesize neurotransmitters is compromised, leading to depression, anxiety, and cognitive decline. Hello, I'm your instructor. As we move through this module, we'll dive into the diagnostic distinctions, DSM-5, TR relevance, and the specific research that grounds these nutritional interventions in clinical evidence. We're moving beyond normal lab values to aim for optimal psychiatric function for every patient, understanding the profound impact of biochemical individuality in mental health care. The B vitamins don't work in isolation. They are a synergistic team. B12, folate, and B6 work together in the methylation cycle and neurotransmitter synthesis. A deficiency in even one can stall the entire system, preventing the brain from producing adequate serotonin, dopamine, and norepinephrine. This synergy is why we often see multiple B vitamin markers low in our most symptomatic patients. Let's examine the serotonin synthesis pathway. It begins with L-tryptophan, which is converted to 5-HTP, and finally into serotonin. This process is governed by two enzymes, TPH1, primarily in the body, and TPH2, which is found in brain cells and produces the majority of brain serotonin. Regulating these enzymes is a primary clinical target for stabilizing mood and reducing aggression. Vitamin D enters this pathway as a powerful hormone. It activates the TPH2 gene in the brain, boosting serotonin where it's needed for mood and behavior, while suppressing TPH1 in the gut and placenta. This dual action helps regulate aggression, mood, appetite, and even social behavior. Without adequate vitamin D, this delicate balance is fundamentally disrupted. Vitamin B12 is the bedrock of neurohealth. It is essential for neurotransmission, neuroprotection, and cellular energy production. Clinically, we see that B12 supplementation robustly supports mood stability and cognitive function. It is a critical nutrient for mental health, particularly for its role in myelin synthesis and protection. We must view B12 as a cornerstone of neuropsychiatric resilience. B12 deficiency symptoms are remarkably diverse. Psychiatrically, it can manifest as irritability, apathy, or even hallucinations and violent behavior. Neurologically, it is vital for the production and maintenance of myelin. When B12 is deficient, myelin begins to degrade, leading to subacute combined degeneration and permanent cognitive impairment. These symptoms can be diverse and vary greatly from neurologic to psychiatric. We must distinguish between normal and optimal. While standard reference ranges start at 200 picograms per milliliter, up to 10% of patients with values between 200 and 400 still show neuropsychiatric abnormalities. In clinical practice, many cases are overlooked because the serum B12 is technically within norms. We must look deeper. The impact on the brain is physical and measurable. Research on 107 volunteers aged 61 to 87 found that subjects with B12 deficiency had the smallest brains and the lowest scores on tests of thinking, reasoning, and memory. This confirms that vitamin B12 is robustly associated with preventing brain atrophy and maintaining cognitive function as we age. Routine testing for at-risk populations is essential. The most common misbelief is you don't have B12 deficiency because you have no anemia. This is false. Your serum B12 might be within norms, but if your MMA is elevated, the deficiency is real. We also see high-risk populations like those with gastric bypass, who are frequently overlooked until symptoms become severe. The research on depression risk is stark. A large Irish study found a 51% increased risk of developing depression in those with low B12. Similarly, a Brazilian study of nearly 15,000 subjects found that higher B12 intake significantly lowers depression risk. Every additional 10 micrograms of B12 intake is associated with 2% lower odds of depressive symptoms per year. These are powerful modifiable factors for your patients. Now let's turn to vitamin D, which is actually a prohormone derived from cholesterol. Vitamin D is a critical regulator of the brain's serotonin synthesis pathway. It activates the TPH2 gene in brain cells, while suppressing the TPH1 gene in the gut, ensuring serotonin is produced where it's needed for mood regulation. Vitamin D also regulates tyrosine hydroxylase, or TH. TH is the rate-limiting enzyme for the synthesis of dopamine, epinephrine, and norepinephrine. Therefore, a vitamin D deficiency can lead to poor enzyme activity, which is robustly linked to ADHD, depression, and anxiety. Vitamin D truly influences every major neurotransmitter system in the brain, including gene expression and synaptic plasticity. When dosing vitamin D, we follow the evidence-based recommendations. For levels under 20 nanograms per milliliter, 10,000 IU daily is recommended. Our goal is maintenance at 40 to 50 nanograms. But remember the Goldilocks principle? Routine testing is critical to maintain optimal levels. This balance is further supported by magnesium, the critical cofactor required to activate vitamin D in the body. Without magnesium, your D supplementation may fail. This brings us to homocysteine, or HCY. Elevated HCY is a strong independent risk factor for cognitive decline, dementia, and Alzheimer's disease. Research from the New England Journal of Medicine confirms that increased HCY levels are robustly associated with cardiovascular disease, Parkinson's, and schizophrenia. Managing HCY is not just about mood, it's about protecting the long-term structural health of the brain and cardiovascular system. Research illuminates robust correlations between elevated HCY and depression. Men with higher HCY show a greater propensity for lifetime major depressive disorder. In children and teens with depression, studies show HCY levels are remarkably high, while vitamins D and B12 are low. This makes HCY a vital modifiable biomarker that every PMHNP must monitor to understand the severity and treatment trajectory of mood disorders. We must also anchor our discussion in vitamin B6. It is the required cofactor for the final step in serotonin synthesis. Without adequate B6, even if you have enough tryptophan, you cannot effectively produce serotonin. This is why B6 status is a key factor in how patients respond to SSRIs. Higher baseline levels of these B vitamins predict a greater response to standard psychiatric treatments. They are the anchors of pharmacological efficacy. Folate, or vitamin B9, drives the methylation cycle. Methylation is a fundamental biochemical reaction that occurs billions of times a second in your brain. It's how we synthesize neurotransmitters, clear toxic catecholamines, and regulate genetic expression. Folate is the required cofactor to metabolize toxic homocysteine back into harmless methionine. Without it, the brain's biochemical engine literally grinds to a halt. A critical clinical pearl. Synthetic folic acid can actually block the transport of active L-methylfolate across the blood-brain barrier. For patients with MTHFR variants, this is a major hurdle. We always prefer biologically active L-methylfolate, which allows for unhindered transport into the cerebrospinal fluid. This is especially vital for those with SSRI-resistant mood disorders. Folic acid inhibits the very transport your patient needs most. MTHFR gene variants, like C677T, reduce folate conversion efficiency to less than 30%. These variants are associated with depression, bipolar disorder, and ADHD. Research shows that for patients failing SSRIs, augmenting with 15 milligrams of L-methylfolate daily significantly improves outcomes. It's about bypassing the genetic roadblock and giving the brain the biologically active fuel it needs. We always recommend starting low and titrating as needed. Folate status is a powerful predictor of relapse. In a study of 71 outpatients, those with low serum folate had a 42.9% relapse rate over 28 weeks, compared to just 3.2% for those with normal levels. Low folate is also robustly associated with poorer response to antidepressants like fluoxetine. Screening for these nutritional markers is not optional. It's essential for achieving long-term stability in our patients. To summarize, B12, B6, folate, and vitamin D are not just vitamins. They are essential chemical cofactors. By ensuring their optimal status and monitoring markers like HCY, we address the root causes of many psychiatric symptoms and significantly improve outcomes. This diagnostic strategy is how we change lives and offer true recovery in mental health care. Thank you for your commitment to this integrative approach. Your key takeaways: target optimal B12 and D levels, monitor homocysteine as a modifiable biomarker, prefer active L-methylfolate, and always balance vitamin D with magnesium. Thank you for joining me for this module. In our next lesson, we'll discuss the synergistic roles of zinc and iron in psychiatric treatment. I'll see you there.